Dear colleagues, here's Dr. Tom Katz from Hamburg, Germany, and I would like to present a case of explanting a multifocal lens out of a torn bag. The lens was implanted in a clear lens extraction surgery and was seen central at the end of the surgery in spite of an anterior capsular tear. The next day, however, the tear was much larger, extending to the posterior capsule, and the multifocal lens was decentered, but still in the capsular bag. That's how it looks like. On the next day, what should we do? There are several surgical options. We could fixate the existing MIOL with scleral sutures or the flange, or we could explant the multifocal lens and implant a monofocal lens in the sulcus or an artisan iris glow monofocal lens. Or what we have decided here is to explant and implant a multifocal IOL in the sulcus, which meets the expectations of this patient. The surgery was done under local anesthesia, and then injecting viscoelastic above and under the lens, and then releasing the haptics of the lens from the capsular bag into the sulcus temporarily. This would be the first level. At this stage, we already encountered a problem. We noticed that there is some vitreous in the anterior chamber. You can see when pulling out the Sinski that the vitreous does exist in the anterior chamber, which necessitates, of course, an anterior vitrectomy before we continue to pull the lens out. We do the vitrectomy under the lens and the irrigation above the lens. Then we add viscoelastic below the lens to create some kind of tamponade for vitreous prolapsing, and then we continue to an anterior vitrectomy to release any kind of attraction of vitreous. Then we can continue with releasing the lens, this time from the sulcus to the second level above the iris, where the lens will be safe until we perform other manipulations. Of course, we will have next to explant the lens in order to put a new lens. Now the lens is sitting safely on the iris. Nothing can cause the lens to drop down, and we have all the time to plan next. We can implant the lens without expanding the tunnel or without cutting the lens. This is a hydrophilic lens. The technique is simple but needs some experience. We use a lot of viscoelastic, then we pull one haptic through the tunnel, and with a McPherson forceps holding at least half of the optic, we can rotate the lens inside the anterior chamber, protecting the endothelium with a spatule, and pull gently out. I will show you that in slow motion. We take out one haptic, then we insert a McPherson. The tunnel is not widened, this is still 2.4 millimeter, and then we also use a spatula above the lens to protect the cornea during 180 degrees of rotation. Now we do the rotation slowly and we pull the lens. We can see a big deformation of the globe, but it did not cause any damage, fortunately, and the lens is out. The take-home message is that if we have an anterior capsule tear extending to a point that we could not recognize, we would rather not implant the lens in the bag, but primarily implant a multifocal lens in the sulcus. If we have to explant the lens, it can be done safely by rolling the lens inside the anterior chamber and pulling it through the original tunnel. Thank you very much for watching, and the next video will include the rest of this case. Thank you very much.